Good morning, colleagues.
Good morning, everybody. Can you hear us?
Yes, excellently.
Thank you for the connection, and thank you for the opportunity to present and to be able to work live with this case. We have here our esteemed guest, Professor Şevket Yorgovu, who is a world-known CTO expert, and we are very lucky to have him here. And we want to thank the organizing committee for inviting him and to thank him that he accepted our invitation. So he's a very, very famous and very good operator, CTO expert, so we're very, very lucky to have him here. So maybe we have our nurses here, Jenny, Nadia, Dr. Popova will present Professor Vasilyev the case that we are currently doing. So maybe to show the presentation.
Good morning, everyone. I'm Dr. Anna Popova from University Hospital Alexander Cherkov, and today Dr. Dimitrov and Professor Şevket Yorgovu are going to perform the procedure, and it's my pleasure to present you the case. It's about a 64-year-old male patient admitted to our hospital with stable angina class 3. According to the Canadian Cardiology Society, for the past 3 months, the patient has family history for first-line relative with ischemic heart disease. Amongst the other risk factors are age, sex, diabetes, arterial hypertension, and dyslipidemia. The patient was previously admitted to another hospital where coronary angiography was performed, and it established two-vessel disease with CTO of LAD and significant stenosis of right coronary artery. The patient was offered surgery, but he declined that option. As for his comorbidities, he has arterial hypertension for the past 10 years with good control on medical therapy. He has dyslipidemia on triple therapy with rosuvastatin, ezetimibe, and fibrates, and he has diabetes for the past 8 years on triple drug therapy. Amongst the other medical therapy he takes, there's acetylsalicylic acid, beta blocker 2.5, and PPI. This is the ECG at administration, sinus rhythm, no ST changes at rest, and the echocardiography showed preserved LV function with no motion abnormalities and no valvular disease. This is the coronary artery angiography performed in the other institution. Again, the chronic total occlusion of LAD, distal lesion of circumflexa probably, and long lesion of right coronary artery. We're going to perform another diagnostic, so to be more precise. The patient sought our hospital for second opinion as he declined coronary artery bypass grafting, and we advised him to perform perfusion myocardial scintigraphy, SPECT-CT. These are the results, no fixed perfusion defect. When the patient was loaded at 100 watts, they were exhibited ST depressions in the inferior leads, 2.2 millimeters, and periapical perfusion defect, which was quantified 7% of the LV myocardium. Again, no LV dysfunction at the rest and the stress, except for mild septal hypokinesia. So, what's our strategy then? We calculated the syntax score to the patient, 1, 2, and the one from 2020 for the 10-year mortality. These are the results. And according to the guidelines from 2018, a large area of ischemia detected by functional testing is indicated for revascularization in a patient with stable angina class 1 level B. So, one more time, let me remind you that our patient refused coronary artery bypass grafting. So, what was our plan for today? To start with antegraft wiring with microchannel tracking, Fielder XT, escalation if needed. Then I was of left main LAD and first diagonal, hopefully PCI with novel Nagomi stent, and if unsuccessful, we're gonna proceed with retrograft through the interventricular septum collaterals from right coronary to left. These are the progress CTO score and JCTO, which were 0 and 2. So, thank you.
Yeah, thank you, Anna. I will take over from here. Or For the beginning, I would like to thank the Bulgarian Society of Cardiology for having me here. It's a great pleasure and honor, so to say. And I would like to thank also Dimitar and Professor Trandilova for this nice invitation. So we would like to show you what we have done here so far. We have already the setup. We have a right femoral and right radial setup. And right femoral is a 6.5 Asahi shitless guiding catheter. And the left main, it's an extra backup 3.5. And we have a Judkins 3.5 in the right coronary artery with the Sion Blue extra support. And we have some dilemma here. We discussed the case with Dimitar before, and we have an LAD C2, JC2 score, it's 2. But we have calcification there, and we have a lot of side branches coming out of the before the CTO, and there is an issue with the RCA. So we first discussed whether the RCA is severe or not, should we treat it first or not, but the final decision was we're going to do the CTO first, and if you're going to do retrograde approach, if we need a retrograde approach, then we will make an FFR on the RCA. If it's severe, then we will go on with some kind of stenting before we go retro. That was our goal. Let me show you the setup shots. Can you begin from the beginning?
Can you show the angio, please? Do you see the angio, Professor Vasiliev? Yes.
Yes.
I think you can see it. Okay, so this is our diagnostic procedure. We have the two guides, as Professor Shivket said.
And we have immense calcification, at least moderate there. It will hinder us, I think, to make a proper advancement of the wire, and it will push us towards the side branches. So there is no easy CTO. It seems to be a little bit short, but it's tricky.
Can we see some projection, for example, AP cranial 40
We
degrees?
have done.
Yeah, we have.
Very steep AP. Because
so we have retrograde options. We have septals, and we have an epicardial. But as you can appreciate, it's very difficult in RCA cases to go retro.
So your plan is to go directly retrograde?
No. We will first do the antegrade approach because we have some kind of cap there. You know, it's going to be a septal. Then we have to go upward, and we will do first antegrade wiring, and then we will do parallel wiring. And if it doesn't work, then we will try to go retro. But first, let us try and probe the proximal cap. You see, but it's a little bit ambiguous. It's not ambiguous, but it might be ambiguous if we are going to do to puncture where we intended to go and end up somewhere else. So we will try to puncture antegradely. So we discussed first that we're going to do within filter XDA, but I changed my mind. You see here, I will go first within filter XDR. So Corsair Pro 130 and filter XDR. And in the meantime, we will begin to work. The patient is now a little bit sleepy and our pressure is good. And I will take advantage of this and begin with the work. And in the meantime, you can discuss the case, and please feel free to ask something during the process. So I need 130 Corsair and a filter XDR, please.
Okay, so maybe while you're starting, we'll go with another center just to present their cases,
that would be
and then
nice.
we will go back to you to see to what point you are. Можем ли да включим Токуда? Добро утро, колеги. Ива,
So you think
Nikki?
What do you think? So,
здравейте, Валери.
good morning
Good morning.
from Tokuda. It is pleasure to
Hello, Bernardo.
to be with you this morning. I have the pleasure, of course, to work with Dr. Cortese We already started the case, and now we're going to present it to you.
Dear colleagues, dear panelists, hello. My name is Dr. Savova, and I have the opportunity and, of course, the honor to present you our today's live case. So here with us, on the table, excuse me. Here with us on the table is a 63-year-old male with symptoms of stable angina, second to third functional class, with the typical risk profile, including hypertension, dyslipidemia, and known episodes of atrial fibrillation, and performed isolation of the pulmonary veins in the past. Nothing special on the EKG on admission. He's in sinus rhythm with no ischemic changes at rest. So as the echo, which showed us normal ejection fraction of the left ventricle of 55%, no segmental kinetic changes at rest, and one minimal mitral insufficiency. As you can tell from the therapy on admission, he is on an optimal one with DOAC, besides his AFib, dual antiplatelet therapy, beta blocker, ACE inhibitor, optimal dyslipidemic therapy with statin and ezetimibe, and of course PPI. Our first initial contact with the patient was 6 months ago, at the beginning of this year, 2023, and he was referred to us for an angio based on symptoms of chest pain on exertion and during the episodes of his atrial flutter. So from the angio we performed, we found a significant tree-vessel disease with severe stenosis, as you can appreciate, on the proximal part of the circumflex artery, lesions at the distal left main, ostial segment of the LAD, and proximal part of the LAD. So our next step, and to stenosis at the proximal and mid segments of the right coronary artery, around 50%. So our next step was to perform dobutamine stress echocardiography, which showed us a significant inducible ischemia in large zone from the system of the left coronary artery with 4 segments from the LADs, 2 segments from the circumflex artery. Patient being a good candidate for CABG, including, was offered one, but he refused. So our first initial step was to intervene the severe stenosis at the proximal segment of the circumflex. So we implanted one disc with this final result, as you can appreciate, which was really good. And then we performed an IVUS of distal left main, which was 8.38, of the proximal part of LAD, which was 3.82, and the ostial segment of LAD. Actually, the IVUS showed us severely and diffusely diseased LAD with severe stenosis at the proximal part and diffusely diseased distal left main and ostial part of LAD. So we don't have any healthy part to place a stent only in the proximal part. So we decided to stent the left main to cover the ostial part of the LAD and to stent the proximal part of the LAD. So we used 2 drug-eluting stents with this final result, as you can appreciate, really favorable. As a routine practice in our clinic, we always try to perform another control angio 6 months after the left main PCI in all our patients. So the patient came, we performed the angio, and we found a severe restenosis at the stent in the proximal part of the circumflex and severe restenosis in the stent at the mid-segment of LAD. So
wait a minute, is there a stent or in the LAD, in the mid-LAD, there is also the stent, because the first part, as I understand, you stented the left main only in the proximal LAD. No. This is mid-LAD with the bifurcation, and I don't see stent there. Maybe because of the transmission. Okay.
So we performed another debutamine stress echocardiography, which showed us again almost the same result as the first one we had before the procedures, with induced ischemia in 3 segments of the LAD and 2 segments of the circumflex artery. So thank you. I'll leave you in the hands of.
Yeah, we should comment about this patient. He's a frequent flyer. This year he received 5 or 4 cuts. And the restenosis is a big issue because he had a first stent implant and then restenosis, then DCB, paclitaxel DCB, and now we are, before deciding the treatment, we need to understand what's happening in this vessel. So for this reason, we decided with Valerie to do an IVUS. So can we show the IVUS result? We did the circ first.
So you did the IVUS in the circumflex and then IVUS in the LAD.
Yeah. Now we started with the circ.
Can you enlarge to zoom the
Maybe you can zoom.
IVUS zoom? Yes. Okay. Excellent.
Yeah.
Okay. So this
So this is just this
high definition
stent.
IVUS from assist.
Yeah. And so this is the most diseased part. Then here we can appreciate that probably the stent is a little bit undersized as compared to the actual vessel size. It was a 2.25, was dilated with a 2.5. The first time. And the second time they used a 3.0.
What are the sizes of the of stents implanted in the LED?
No, this is the circ.
Ah, this is the circ. Okay. What was the size of the stent in the circ?
2.25.
225.
Yeah. All dilated with 2.5, and then the restenosis was treated with scoring balloon 3.0.
You implanted stent 225 and then treated the restenosis with 3.0.
Yeah.
Okay.
So now we have an area which is distally around 2, what is it, our measurement before. It's a really small vessel. So this is, this is probably the ostium. This is the ostium of the circ. It's still diseased at 2.9 millimeters square, and distally it's even less. It's around 2. Yeah, 2.8. All right, 2.8.
On the ostium. Yes.
Yeah. So I think that I would like to have your opinion, Valerie, also, and the one of the panel. Because, this is the third time that in 6 months we need to treat this lesion. We want to be, this should be the last one, hopefully, for the patient. So it's not, in my opinion, a matter of which device using a stent or a DCB, but to address the problem that is coming. So, Valerie, which is your opinion?
Well, it is unusual to meet restenosis. Probably there was an issue with the small stent, but finally we can see that this issue we have in the LED, which is really the right time of, the right timing for the restenosis. It's between the 6th and the 7th month that we have this, and I'm pretty sure that we treat properly this patient, and if I'm not mistaken, we have done an IVUS during the treatment of the left main and the previous intervention. And we should not forget that even it is really rare, but we have some percentage of what we know. We have forgotten the instant restenosis, the Achilles heel of interventional cardiology before drug-eluting balloons. But here we should probably go optimize the stent, if possible, but if not, try with drug-coated balloons, especially I'm speaking about the circ. And if we don't achieve optimal result, probably an option is to go for a stent.
All right.
Because it is obvious that this stent is underexpanded and probably there is a recall because of the small size.
This is, yes, a small size stent with the thin struts that in calcific lesions can be an issue, in my opinion. So, yeah, I totally agree with you. So, first of all, we have to optimize this to face So I don't know the panel.
Guys, can
what
you
do
show us the IVUS from the LAD, because
We haven't done it yet.
okay.
Yeah,
Because
we would
in
like to
general,
focalize
this
and finish
maybe 3-vessel disease patient, or even 2 vessels with the frequent restenosis, and this is the the next restenosis, and maybe it is wise to ask patient about surgery.
Yes, we discussed this with the patient, but he refuses.
Okay.
So the problem is solved.
No, really, we discussed with the patient, because if you go and see the angio, probably you can see that there is not significant, but some proliferation of the proximal part in the AOD and in the left main. We hope that it will remain in this way, and probably it will not expand, but this is an option that was already discussed. From the other side, AOD, please correct me if I'm not, the restenosis is AOD is focal. It is very short one. And from my point of view, we should give the chance of these patients to be treated properly with rat-coated balloons. And if the AOD is solved, how to say, I can accept this with not excellent result. Having in mind that he is not that symptomatic, and we have only 2 segments of myocardial ischemia.
Yeah.
So it doesn't have, we don't have an issue with the prognosis of this.
Yeah, we don't have to be too aggressive. I agree with you. So do.
Okay, so we'll wait for the IVUS when you just work quietly, and we will switch to City Clinic.
All right.
Thanks.
To see their case, and then we will go back to you, just to show us the IVUS from the LAD and what you are doing. Може ли да превключим на къв в City? Здравейте, колеги. Здравей, Иво. Дали ни чувате? Доколкото знам, те се готвят.
Okay, чуваме, бе. Let's connect it here.
Може и на български, защото панела е само от българи. Като гледам...
Okay, let's flash this. We will need a very full syringe of the sound.
Явно от време на време ще случваме от български на английски, защото ние имаме проктори.
Не, окей. За смисъл... Аз ти казвам, че може да говорите на български с залата.
Чудесно. Окей.
Мисля, че ще е по-лесно.
Okay, let's flash the side port first.
Може ли някой да представи кейсът през това време, за да не губим...
Всъщност ние имаме кейс митраклип на пациентка, която... Добре. Окей, нека ние докато приготвяме системата, правим флаш.
Да.
Да видим... Къде искаше представи случая?
Добре.
Здравейте на всички, казвам се Румяна Кадийска и съм първа година специализант по кардиология. За мен е удоволствие днес да ви представя случай на пациентка, която ще се инфектира вторична степен на митрална инсуфициенция. Да започнем с малко данни за пациентката. Тя е на 68 години, презентира се при нас с оплаквания от лесна умора и задух и минимални физически усилия до степен на ортопнея с давност от август месец тази година. Пациентката съобщава, че има оттоци по долните крайници и пароксизмална нощна диспнея. Жената е с прояви на сърдечна недостатъчност 3 до 4 функционален клас по класификацията МИХА и триклонова коронарна болест, която е оперативно реваскуларизирана предходно в болница по район месец март тази година. Както виждате на екрана, тя е хоспитализирана на двойна антиагрегантна терапия с клопидогрел и ацетилсалицилова киселина в стандартните дози. В последствие, на фона на тази медикаментозна терапия, пациентката реализира латерален стент, което се случва месец юли тази година. Тогава отново е доведено ендоваскуларно лечение, като се дилатира венозен граф към циркумфлекса и надиван първи маргинал. Постпроцедурно пациентката е с прогресия на митралната инсуфициенция, която в този момент е била описана по-добре. Също така е имало оплаквания, подобни на настоящите, с които стъпват стъпвайки при нас.
Имаме ли възможност да изключим микрофона
с
на
артериално
проктора?
налягане, както виждате, 1/60, а аускултаторно дишането е отслабено в двете белодробни основи, като аускултацията на сърце ни показа холосистолен шум с декрещендо характер и по максимум в ляво междуребрие. Крайниците към този момент на прегледа бяха без пустоти. Кардиограмата е интересна с слушен позиционен тип, слушен бедрен с давност. Тук съм ви свадила малко снимки от ехокардиографията на пациентката, като проведохме трансторакална ехокардиография и трансезофагиална ехокардиография, за да можем да оценим клапната патология точно, като, както виждате, ринга на митралната клапа е 39 мм. На втората снимка можете да видите джета на митралната регургитация, който изпълва цялото ляво предсърдие. Тук можете да видите изчисления на пиза на митрална клапа, която отново ни доказва, че пациентката е с високостепенна вторична митрална инсуфициенция вследствие на латералния стеми, който реализира юли месец. Тук на втората снимка виждате надлъжния размер на предсърдието, който е 38 мм и всъщност това ни показва още веднъж, че можем да извършим процедурата, която ще видите след малко. На другата снимка отново виждате джета, който е централен и формира голяма пиза. Тук, за да се ориентирате малко по-добре, съм представила едно кратко клипче на коаптацията на платната на клапата и отново джета. Като нашата пациентка на фона на високостепенната митрална инсуфициенция се презентира с фракция 49%, фракция на изтласкване, което за наш късмет е над 20%. Виждате размерите на съответните платна 13 мм и 25 мм, като отново е показан размера на ринга на клапата. Тук е важно да отбележим, че на фона на оптималната медикаментозна терапия пациентката не е с високостепенна трикоспидална инсуфициенция. В предходни хоспитализации има данни, че при декомпенсация на състоянието е била с белодробна хипотония до 55 мм живак налягане в артерия пулмоналис, но към момента на хоспитализацията тя е до около 17 мм и тапсето е запазено над 20. Трябва да отбележа, че това са резултатите на пациентката от август месец, което е 5 месеца след оперативната реваскуларизация и 1 месец след ендоваскуларното лечение по повод латерален стеми. Както споменах малко по-рано, тя е дехоспитализирана на двойна антиагрегатна терапия с аспирин и клопидогрел, като виждате неоптимален резултат от АСПИ теста. По повод на който ние взехме решение за терапевтичната стратегия пациентката да остане на 2 таблетки клопидогрел, на фона на които към момента тя е напълно реваскуларизирана и няма повторни коронарни синдроми. Тук ще обърна малко повече внимание на оптималната медикаментозна терапия, която пациентката приема, именно диуретична терапия с фуроземид, която е интензифицирана до 3 таблетки на ден, спиронолактон, бета-блокер, статин за дислепидемията и коронарната болест и пантопразол, който да ни предпази от кървена отвит. Тук трябва да отбележа, че не сме добавили инхибитори или арни към терапията на пациентката поради склонност към хипертония и поради абсолютно невъзможност от нейна страна да ги толерира и поради данни от предходна хоспитализация за нормогликемична кетоацидоза на SGLT2 инхибитор.
Аз да се извинявам, само пациентката диабетичка на инсулин ли е?
Не ви чух, извинявайте.
Пациентката диабетичка на инсулин ли е?
Не е диабетичка на инсулин, но това е един от страничните ефекти, независимо дали пациентите са диабетици или не, на SGLT2 инхибитора.
Ама, леко ни изненада тук всички. Добре, окей, давайте.
На този слайд можете да видите евроскора на пациентката, който е екстремно висок. Това, което най-много вдига скора, е предходното оперативно лечение на пациентката и ограничената подвижност, която всъщност е заради дисковата херния, която тя има, и поради интензифицираната диуретична терапия и дехидратация в момента е с доста обострено състояние. Както виждате, скоро е 12,15%. На кардиохирургичен колегиум, предвид всичките данни, които описах до момента, преценихме, че пациентката е показана за имплантация на митраклип. И на този слайд всъщност можете да видите в червено самоградила критериите, които тя покрива. Благодаря ви за вниманието.
Окей. Някакви въпроси? Ако искате да ви представя нашите колеги, с които работим.
Давайте.
Окей. Към камерата. We have Slavik as a proctor. Thank you for Slavik for coming, and also Rafa. Since long time ago, we are working with him. Thank you for coming, both of you. And of course, I have my excellent team here: Dr. Stankov, Katie, our scrub nurse, Lydia, the X-ray technician. Доктор Гецов, доктор Димитров, те са експертите. Вчера стана въпрос, че това е процедура, имплантирането на митраклип е процедура, при която се разчита на имиджинг контрол от трансезофагиалното ехо. Така че имаме възможността и щастието наистина да имаме експерти като наши съпортъри. Професор Трендафилова вчера ви спомена, че повече от 200 случая продължава учебната крива, learning curve, така че ние сме сега на 13-тия си случай, още сме в началото. И така, ако имате някакви въпроси, слушам, ако не, ще ви кажа какво сме направили до този момент.
Давай, Иво.
Добре, както разбира се знаете и Валери показа вчера, първата стъпка при митраклипа, разбира се, е да се направи трансепталната пункция, която не беше съвсем лесна в случая, но така или иначе успяхме да направим достатъчно висока и постериорна пункция на септума. Ще помоля Лидия да започне от начало на флорото и колегите от Ехо Тим, ако могат да покажат записите, които направихме при трансепталната пункция. Няма някаква голяма тайна. Вие знаете, че първо се отива с шиита, с интродюсера в вена кава, както се вижда в случая на ехографския образ. Виждате много добре шиита, който е позициониран в вена кава, и отиваме след това надолу, както на флороскопията виждате, така и на ехото. Давай следващия. Да, сега вече сме близо до фосата с катетъра, виждате долу. Давай следващия литка. И всъщност, както се казва, се играе. Чудесно се вижда ехографски в момента тази палатка, този тентинг на междупредсърдната преграда, точно преди да се премине през нея, и всъщност този тентинг дава възможност да се измери разстоянието между върха на тентинга и разстоянието до митралната клапа. Ето сега вече е преминато, вижда се много добре. Надявам се, че виждате на доста ясния образ. че вече се премина през септалната преграда. Както споменах, очакваме едно разстояние поне от 4 см между мястото на пункцията и до митралната клапа, което това пространство да даде възможност за манипулиране на върха на катетъра на деливери системата. Като следваща стъпка промихме всъщност катетъра на деливери системата и след това позиционирахме самия шиит, който, ето аз го посочвам, шиита го позиционирахме през вече извършената транссептална пункция, като върха на този шиит, разбира се, улеснява неговото преминаване с конусовиден дилататор. И така, използвайки конусовидния дилататор, виждате вече, че тази леко приличаща на вертебрален катетър кривка вече е преминала. Това, което виждате на екрана на флуороскопията, е вече лайв. Тоест виждате, съвсем умишлено направих регистрация, виждате, че деливери катетъра вече е преминал през септалната преграда и е позициониран в предсърдието. Върха на катетъра, нашите колеги от ехотима могат да покажат, че върха на... Ето сега вече много добре се вижда на ехото. Върха на катетъра, който е по средата, приблизително по средата на предсърдието. И сега всъщност ще стартираме с позиционирането на самия митраклип, който ще трябва да премине през шиита, през интродюсера и да го позиционираме върху по посока на митралната клапа в две взаимно перпендикулярни аксиални позиции, за да можем да направим съответно захващане и след това освобождаване. Някакви въпроси до този момент?
Не, ясно е. Много добре визуализираш. Давайте напред.
Добре, продължаваме. Всъщност с клипа. Между другото, обсъдихме, we have discussed with our expert team here, our proctors, regarding the type of the clip. You know very well the previous version and the new version that is a little larger, the XTW, and we have discussed that the jet of the regurg is quite big. The leaflets are long enough to accommodate XTW, and we decided to use the last version XTW. So this is a little longer and wider compared to the previous one. And with this strategy, with the idea to do a good result with one clip. Slavek, do you agree? Yeah,
definitely.
So our strategy that we have discussed is to put possibly and hopefully one clip that will reduce in a sufficient extent the torrential mitral regurg that we have in this relatively young lady. So we are preparing the XTW, please. Окей. Цялата система изисква сериозна подготовка, най-вече в промиване, флашинг. И това е абсолютно задължително, тъй като дори и малки...
Take the red cap over here.
The red cap. Дори и малки бъбали и малки всъщност...
Okay, take the stopcock over here. And Zoran, you connect both those lines.
Is it possible? It's probably not very possible, but in fact I wanted to show how important it is to flush everything.
Zoran, rotate to have like a mitra clip and the opposite. Yeah, so this, Zoran, this, okay, it was okay. Rotate counterclockwise. Yes, like this is the zero position, but this goes down and the red cap goes over here, okay?
Промираме всичко.
Okay, and secure with the blind cap, Professor.
Yeah.
Yeah, to have it. And now we can open it for Zoran.
Okay.
Open it. I don't know if it's clean or it's... Okay, open it to maximum. If it's clean, you have to open it to maximum.
цялата система трябва да бъде много старателно напълнена с физиологичен
Flush the
разтвор.
side port and put to the device. Okay, put it to the device, and now Zoran, open and do the pumping. Professor, raise this tip and make sure that tap along.
Иво, Арман, един въпрос само, ако, понеже малко трудно е да проследяваме това, което правите, ако нямате нищо против и това ще се забави, нека да минеме отново към Света Екатерина и след малко да се свържем отново.
Да, всъщност сега правим старателно промиване на цялата система и след това ще я позиционираме, така че абсолютно да, съгласен съм.
Благодаря. Ако може отново включване към Чирковата клиника.
So I will change the,
Нека да превключим на Чирков.
Go down, please. Let me see which one is which. Go down, please.
Hi guys.
Okay.
Hi guys.
This is the one. We go with this one here.
Where you are, I see that you have, what is that, Gaia?
Yeah, this is a very educational case, step by step. Let Dimitar, let us go from the beginning, okay, what we have done here. So we are still struggling, that's a good thing, because we have a lot of things to show you how we are doing in antegrade wide escalation, okay?
So this is where you left.
This is the Sion blue. We will just trying to go into the proximal cap. Next. So now next. So I have retrieved the Corsair to have a better free movement of the wire to engage the proximal cap. You see how it's buckled there? Now this is the proximal cap. And now I am trying to bring my Corsair there into the proximal cap. It's buckling there, but I have to be sure that the wire gets not looped. So now I am in the proximal cap. So this is the filter XDR, and you see how nicely it is going. I am in the architecture, I am following. You see the buckling of the wire there? That means we have to escalate, okay? So then we escalated to ultimate Bros 3, and we will still checking where we are. We are in the architecture for sure. And here comes our Corsair taking the curve, and you see the buckling there. That means the ultimate Bros 3 is also not, let it play. You see, it's not enough for us to go through the lesion or to make a progress here. And then we went with you see this is still the ultimate Bros. It's not behaving like we are in the architecture or in the true way. So then we escalated to Gaia. You will see the retrograde injection. We are not far. Take another. Yeah, this one you see here we are. Next one maybe. This is the better one. Yeah.
This is the better one.
So we take from different projections where we are. It seems we are on the course here. Next.
Sorry, that was which wire is that?
This is ultimate Bros.
Ultimate. Okay.
Yeah. Still go. And let's see the projection. Now you see how it's buckling. I cannot make a way. The wire is saying to you, you should change me to a stiffer wire. So it's crying, it's shouting, you should change me. But you see we are here out somehow, but we are in the architecture for sure. That's a good thing. And now I am changing to Gaia. And you see how the Gaia is Gaia third. This is Gaia third because we have calcification there. And you see I am out. With Gaia third, this is not, we can't be sure whether you are in or out. It can be easily out because it's a very stiff wire.
It's look like
you have the feeling. Yeah, it's out. So now we are trying to redirect our wire here. You see. Next one. And then we are out. So we did parallel wiring. Here, this is another Gaia third. We are somewhere, but I don't have the feeling that I am on the right track. So here, this is also out. Go. So this is our last image, okay? We are here in the architecture, but out with two wires. Now, I am changing the Sasuke with the, not the wire below, I am putting the Sasuke on the wire below, and then I will try parallel wiring again. And if this doesn't work, then I will try to go retro, okay? So I don't want to destroy the architecture too much, but I still want to go integrate because I don't rely on the RCA because we have some kind of lesions there. So, but I will try again with Gaia third and with Sasuke. Now I am putting my Sasuke below the wire. So we have
to be.
Yeah, we have to. Yeah. No. You don't have.
So you passed with the
Okay.
with the Corsair.
Yeah, we were with the Corsair now.
I mean, you passed with the Corsair through the body of the occlusion, and then maybe it is good to check is in some another projection, because I see that you work all the time only one projection in areocranial. But sometimes it's good to check in the, let's say, epicranial or shallow areocranial, just to see and to inject retrograde just to see where this wire is, because it could be that this is some secondary diagonal, because from the passage of this second wire, it seems that it goes into the myocardium. And this is a good thing, because with the Sasuke you can remove the first wire and then to redirect to go into the proper lumen of the LAD, just as a suggestion.
Yeah, very good suggestion.
This is exactly what we are doing here now. You see, I have changed my Sasuke.
You're with
the wire below.
7 French catheter, or that was actually Asahi sheetless?
It is Asahi sheetless technology. We have 8.5 French guiding catheter, which is with the outer diameter of 6.5. In our experience, it's a very useful catheter. Unfortunately, Asahi will not sell it anymore in Europe, but we have quite some experience when we have complex procedures using this guide, because we benefit from not the big outer diameter, but the big internal diameter. So we find it very useful. It's actually designed for radio approach, but we decided, because we are now using from the radio the new sheet from Terumo, the glide sheet slender, which is a perfect sheet for me. It has outer diameter of 6 French, but inner of 7. So we have a 7 French guiding in the RCA with a 6 French sheet. So we have good support. We have, unfortunately, we were thinking that we're going to recanalize easier, or at least I was. Professor Shevket was cooling me down. I was quite excited at some point of the procedure. But hopefully we can.
So now I have another resistant point here. So I'm trying to find a resistant point. Where can I puncture? Okay, full store. And my threshold is very low when I switch to retro. But in this case, everything is good. The pressure is good. The ACT is good. We have 2 pressure measurements from the right and from the left. And we are in a good position, but I will try to invest some time more. And if this doesn't work, then I will try. We have punctured a lot from a lot of positions. That means we may have created some kind of fenestration. My last shot would be go with a gladius. And if this is not working, then I will switch to retro. This is my plan now. So you can be with us with some minutes to see whether this is going to go now.
Still have internal impression that there is a huge overlap between diagonal and LAD in areocranial, and you should probably change the projection in some another plane and then to inject to see where the division, because there's probably a distal diagonal where you are, and you are going all the time in this direction. No,
what I am trying to do here is to find the resistance, okay? So unless I don't find the resistance, there is no room for me to go to another you know, to another direction. So what I am trying to do is just try to find a resistance. And you are totally right. I have to make my puncture from the beginning and trying to find the resistance and go from there. And then I will do what you are doing. But let's make what you are suggesting. Okay, we can go to epicranial and you will see. I have already made that in my mind. I know the map already. So
can we go
I know
on the epicranial 40 degrees cranial?
Okay,
just,
okay, make
just
epicranial,
because
okay.
this is
Yeah,
probably the best for proximal LAD diagonal to just to diverge and to see the carina where you are.
Okay, we are doing according to your suggestion. Okay, let's make a
retro.
cut. Yeah.
Retro and then antegrade.
No, not antegrade because we don't want to make a hematoma. So we have made a lot of puncture there and I don't want to increase the hematoma.
Okay,
so that's
but
the reason why I don't want to make an antegrade.
It seems that you're in some diagonal branch which was seen from the beginning. If you observe your beginning angiogram, it is always useful.
This is not a diagonal, I'm out. With the first wire, I'm out. If it were a diagonal, I would have seen some feeling and my feeling on my hand is not that I am in an artery. It's like I am in a pericardium or something, okay? So you were right from the beginning.
So maybe we'll leave you to work quietly and we will switch to CUDA just to see their IVUS.
Okay, thank you very much.
Thank you.
Thank you.
Good suggestion. You see here, I have some kind of resistance.
Може ли да превключим в CUDA?
8 or 9.
9.
Hello guys. I see that you are already on the balloon dilation.
Yes, normal.
Can you explain what you have done and what you are doing, Valery?
We are back.
Yeah.
All right. So what we said before, we tried to do. We were quite aggressive in preparing the lesion and expanding further the stent because, you know, this stent is not a very impressive radial force. We saw at the IVUS that still it has some difficulties in expanding correctly despite the calcification is not huge. But in the end, we were able to obtain a good area. So we use OPN balloon at high pressures all along the stent. We can show the last shot. Sorry. And then we also prepare with a cutting balloon, actually with a wedge. So with a scoring balloon, the ostium of the circ, which was diseased. We were not happy. And so we used another scoring balloon, obtaining a good area. So in the end, after a good lesion preparation, with
These
Valerie,
are the balloons.
we used DCB.
Yes.
And Valerie had a very good idea of doing two overlapping DCB, long DCB, in order to have more drug at the site of the restenosis, of the second restenosis.
This is the scoring balloon.
Yeah. Now they see it, huh? Right.
Yes.
So
this is the result.
This is the result. Then we did some nitro. And now we have to see what we have achieved after the two DCB.
This is the
it's online.
position of the DCB.
Yeah, we did the stent boost for the position of the first DCB and then overlap. And then now let's see what we have done. Shall we do some nitro first? Any comment?
Can you explain us what is the size of the balloon that you use?
All right. The size is 3/0 by 30. 3/0 by 30, 2 overlap 3/0 by 30. We judge it according to the IVUS. We don't have to be very aggressive with the DCB as we have to do with the stents. So, okay, let's go the scene. Okay, that's very nice. Valerie, I'm more than happy. What do you think?
Yes.
We have no dissection at the ostium because I remember you that the ostium of the circ was not covered by stent. So we did the scoring and DCB. We use a Pantera Lux, which is a paclitaxel DCB. And now I think we can cross directly to the LED, doing the IVUS,
Absolutely.
and then we decide the strategy with you. Comments?
Okay, no. So do you plan to have control IVUS on circumflex artery? After
No, we don't need to do IVUS.
We have done it, and we have a good result. The only thing that we have done after we checked with IVUS is just putting the drug-coated balloon.
I'm curious about the opinion of the panelists here. How you approach this case in general, Arman?
What was the question? I didn't get it.
IVUS.
No.
Yes. How you approach this patient in your cath lab, in your center? What will you do?
Okay, let's centralize it. Like today, so very careful and I would say also
speak loudly, please.
In our center, the first step before the stenting will be for sure trying to put in these long lesions some DCBs. That's what I do, and have a patient back after 1 to 3 months to see if there is a recoil, and if everything is good, we're going to leave them on DCB. If we have this patient with restenosis from other center, how is the case, then we're going to for sure do try him to have the opportunity at least one with DCB. But for sure we're going to use the IVUS to see what is the problem, because you can clearly see that the stent is underexpanded. It was not, maybe the lesion was not well prepared with enough predilatation with a non-compliant balloon. So I will do predilatation, high atmosphere with a balloon which is sized by IVUS, and then long inflations, at least 1 minute, 1 or 2 DCBs, and then check it after 1 to 3 months.
But we don't have the blood pressure. Why? Let's remove this. Remove this.
I ask if you have the patient before the stents in your cath lab, are you someone going to try to treat him only with DCBs?
Yeah. We've done,
maybe they are not hearing you. Dr. Panayotov, Dr. Nikolov, what do you think about this case?
My personal impression for a patient that received 5 angios in the past year is that we have done enough predilatations and DCBs in the past attempts, and maybe we should have gone directly for stenting with a bigger stent in the circumflex. At least this is what I would have done. Perhaps a new depth 3.0 would have been better. And I'm personally not an optimist for the ostium of the circumflex, which is not covered.
Yes, the ostium of the circumflex without stenting, it is, I think, known, let's say so. It will be difficult to achieve any further improvement with the balloon. This is probably the best result you can observe with the balloon.
And personally, for a patient that has restenosis from 2 drug-eluting stents in half a year, I think that the patient should have been better informed that this will happen again and again and again, and ideally the surgery would be the only possible solution in some time. And
my personal view is that after second restenosis, the patient should receive surgery. Just if you treat twice the restenosis and it is obvious that this is a patient with aggressive atherosclerosis and our methods and our treatments are not the best for this patient.
Okay, start. Anyway. Start IVUS.
Okay, so
So now we are online with the IVUS. Can you see it?
No.
The first shot that we are having, let's give a look at the blood pressure, please.
Is it possible to have a better view on IVUS screen? Okay, thank you.
So which was the size, Eva, of this stent in the LED?
Size.
The size of the stent.
Size was 2.75.
All right.
And then 3.5.
Was dilated with a 3.05, 3.5.
The left main is 3.5 also.
Okay. So also the distal part of the stent was post-dilated with a 3.5.
What was the purpose to implant stent 275 and then a distal part to post-dilate with 3.5?
I don't know.
I just wondering, because the stent is not a resign, you cannot extend this stent unlimitedly. Just.
All right. Okay. Stop IVUS.
Anyway.
Let's remove it. The patient is having some ischemia with the crossing of the IVUS at the lesion site.
Yeah, it is critical lesion now.
Fast in doing it. So
I didn't get the question. Sorry, Dobry.
All right.
What is the intention to implant 275 stent and then to post-dilate this stent with 3.5 in the distal part?
No, it is 3.0.
Okay, but
But
huge
the
difference.
intention is that we have a big diagonal and we should respect the rules of putting...
You post-dilated proximally or distally? Because if you distally...
It was post-dilated 3.0 distally, and after that the pot was done 3.5, and as far as I remember,
but I think that
on the left main.
275, go back. Perfect. The 275, look at here, was a correct size for the stent.
No, it is 3, but we always go a little bit undersized, not to compromise the carina, and after that we go for 3, for all stents that we put.
But the stent was 275 or 3?
275,
right.
and after that it was optimized with non-comparable and up to 3.
Yeah, but the larger stent here, this was my point, was probably a mistake, because look at the dimension of the vessel. So here, the size is okay. It's 2.32. It's the average diameter. So here it's okay. Now let's go a little bit more proximal to see the problem. So here it's probably undersized, the stent, as for the vessel. Okay. So let's go more proximal.
The problem with the smaller stents is that you can try to enlarge them in laboratory conditions. It is possible, but in practice, because of the recoil and the elastic tissue of the vessels, it is not very. It's not to, you cannot post-dilate and over-expand the stents. It depends also from the stent, because it is not the same if you have some closed type cell and stent cell design or open cell, or depends on the generation of the stent, and there are a lot of different things. So it is proper sizing of the stent is quite an issue.
I agree with you, and we should not rely totally to the bench tests that the companies are providing us. Also, according to the potentiality of the stent to increase the size. But we would like to discuss with you about this part of the stent.
It's a proximal part.
It's a proximal part.
Close to the ostrum.
It's close to the ostrum. So it's not the very diseased part, angiographically, but there is,
This is just before the bifurcation.
Yes, but this is normal. We have deformated the stent because we have inflated the GO balloon.
So we have to optimize this part.
Yes, we should
just because we will go back to Chirkov Clinic, can you tell us what is your strategy from now on?
So
what do you plan to do next?
We need to optimize the stent, not very distally, but here.
The bifurcation with the diagonal.
The bifurcation with the diagonal to put it to the vessel
This is the
wall.
calcification here.
Yeah.
Is the bifurcation, and where It was post-dilated.
Yeah, it was post-dilated aggressively, but we need to reduce something here.
This between 1 and 3 o'clock is vessel or what is that?
So here we have a bifurcation with the diagonal branch. Do you see also the angel? Let's put the angel, please. The RAO. RAO. Yeah, this one. So here you can look, there is the bifurcation.
Can you switch to angio? Just.
Okay. But they are seeing it. Yeah.
So now you will do what? Balloon post dilation of the stent?
Yeah, I would suggest here to do an aggressive dilatation of the stent, and then again IVUS to see if we have obtained that, and then in the end we decide. If we are not able to achieve a good lumen and a good area with the stent, maybe we can also consider to put a short stent with a high radial force, 80, 90 millimeter. Or if we are able to post-dilate it, maybe with an OPN or with a shockwave. What do you think? You think that given that we have a calcification here, we should use a shockwave?
I don't know, did the shockwave, but try with non-compliant balloon at high pressure. And if you don't achieve really good result, I mean, here any compromising and acceptance of so-called good, it should be excellent result, because this is a patient with a frequent restenosis and you cannot make any compromise with the result. So probably you should go with lithotripsy if it needed, because there is a calcium nodule. That was my point when I tell about the IVUS. It seems that there is a calcium nodule there which should be addressed, and at the moment lithotripsy is the best for this one.
Okay.
So we will leave you and we will switch to Chirkov Clinic.
So we will do a stepwise approach with IVUS after OPN predilatation, and then we decide. Okay, see you later.
Okay, City.
It's better to keep without.
Здравей, Иво.
Здравейте отново.
Виждам, че вие сте вече с клипа в кралкопата.
Да, всъщност ще ви покажа сега това, което направихме степ бай степ, както се казва. Давай следващата флуорокартинка. Да, виждате вече, че това е позицията, при която след като проверихме перпендикулярност спрямо линията на коаптиране и вече са отворени на флуороскопията, са отворени рамената на клипа, от този момент надолу ние започваме да влизаме под шклапата, което нашите колеги ще покажат ехографски как това се случи. Имаме няколко записа. Литка, давай следващата флуороскопия. Виждате в момента. Давай следващата. Тоест всичко се прави под ангиографски и под ехоконтрол. Финната настройка, както се казва, е под ехографския контрол. Така виждате паралелно картината в дясно. Виждате стеблото, както се казва на клипа. Давай следващата. Геца, ако искаш, дай и ти следващата. Така.
Това е доктор Гецов, нали?
Да, това е доктор Гецов.
Добре.
Известния Гецата.
Да.
Така, давай надолу. Много добре се вижда, най-вероятно. Върни една ехографска картинка назад. Най-вероятно колегите виждат как стеблото на катетъра всъщност се потапя под нивото на клапата. Тук правим последен чек на това дали е перпендикулярна уста на клипа спрямо уста, спрямо коаптационната линия. Давай следващия. И след малко ще видите, Литка, давай ти напред, ще видите как се затваря клипа. Литка, давай напред. Виждате и на флуороскопията следващия. Литка, давай следващия. Предишния. Тук вече, сега вече виждате както ангиографски на флуороскопията, така и на ехото, че клипа вече е затворен и е поел платната, които са абсолютно плътно фиксирани към двете рамена на клипа. Ако някой от рамената е добре фиксирано, а другото не толкова, може разделно да се отваря. Да се отваря едното рамо на клипа или другото рамо и да се донастройва предно-задна позиция много често, за да се поеме примерно предното платно, ако не е добре захванато, задното може да остане захванато, системата да се придвижи в предна посока, така че да попадне и предното платно върху предния клип и да се затвори допълнително. Тоест имаме това едно движение напред от гледна точка на системата, което е възможно сега, независимо да се клипсира предното и задното платно. Смятам, че доста добре се вижда, това е вече с цвят. На предишната много добре се вижда, че е много добре фиксирана предното и задното платно. Давай пак цвета, Геца и доктор Димитров. И виждате, че има два миниатюрни джета около раменете на клипа, които в сравнение, може би си спомняте гигантската митрална регургитация, която имахме изходно. Най-вероятно ще попитате за кръвотока в другата посока, в диастолната, т.е. стенозата. Винаги се проверява, особено при едрите клипове, както е XTW, винаги съществува известен риск за ятрогенна стеноза. Така че виждате измерването на средния градиент на клапата, след като сме затворили клипа, и той е 4 мм живак. 7 пиков, 4 среден, така че, както се казва, нямаме забележки от тази гледна точка. Някакви въпроси?
Мога да ви пусна от преди това каква е била.
Каква беше коптационната дължина на платната за захващането като дълбочина?
Достатъчно голяма и на двете платна. Това беше, между другото, първия ни коментар. Доктор Гецов сега ще сподели именно тези
може
данни.
би, защото това ще е интересно в край на краща, това определя реферирането на пациента към процедурата, защото не всички в залата ще слагат митраклип, но е хубаво всички да знаят кога трябва да се помисли за тая процедура.
Професор Василев, благодаря за този коментар. Това е така наречената мултимодална оценка на митралната регургитация и базирано на тази мултимодална, виждате долу на прозорчето каква беше регургитацията изходно. Един коментар, т.е. както дължината на платната, така и тяхната дебелина и наличието или не на калций. Това са все наличието на допълнителни клефтове, т.е. допълнителни цепки по платната. Вчера коментирахме, че платната формално са две, но всъщност те са трипартитни, така че между тези три части може да има така наречените клефтове. И всичко това трябва да бъде много екзактно оценено, за да видим, че пациентът е наистина подходящ от морфологична гледна точка за имплантирането на клипа. Доктор Гецов ще отговори сега на въпроса каква беше дължината, потенциалната дължина за захващане и какви са минималните изисквания. Доктор Гецов или доктор? Да, казвай.
Като коаптационна дълбочина, тук на практика нямаше коаптационна дълбочина, защото двете платна не достигаха едно до друго, поради тентинга на клапата от промяната в геометрията на лявата камера. Иначе дължината на платната определя и вида на клипа, който ще сложим и къде точно да го захванем. Искам само да погледнете на ехокартинката в момента. Това е пулмоналния кръвоток в лява горна пулмонална вена. Виждаме систолик блънтинг на кръвотока и на последната картинка, която взехме, кръвотока стига близо до нормалния след поставянето на митраклипа.
Това, между другото, е изключително красива, в смисъл показва истинския ефект, незабавния ефект на на процедурата практически.
Сега след малко ние измерихме между другото изходно левопредсърдното налягане, което е един от сериозните критерии за успех на процедурата, не само визуалното намаление на регургитацията, но също и
да попитам, защото това е практически най-важният критерий за успеха, непосредствения, колкото и така странно да звучи, но...
Да, имаше драматична промяна, почти 2 пъти падна средното налягане в лявото предсърдие, което ние ще го верифицираме след като извадиме самата деливери система от катетъра, който продължава да бъде вътре, шиита, който продължава да бъде вътре в предсърдието. И от едно налягане, средно налягане, което се приближаваше до 19 мм живак, и огромна V-curve, имаме значително намаление на налягането и което, между другото, тази крива, която Гетста показа ехографски и което много пъти сме си коментирали, е добре да се прави след като артериалното налягане стигне до нормалните стойности за този пациент. Тоест, естествено, когато имаме ниско налягане системно, можем да очакваме и фалшиво, оптимистично ниско налягане в лявото предсърдие. Така че в момента пациентката е с 150 систола, т.е. ние се приближихме де-факто до нейното обичайно системно налягане, за да имаме достоверни резултати, а не фалшиво оптимистични, както би могло да се случи, ако нямаме добра хемодинамика.
Страхотно, Иво. Поздравления, практически вие свършихте работата.
Да, сега следва освобождаване на клипа. Освобождаване на клипа и издърпване на системата, която носи клипа,
добре,
за да можем... Да.
Аз предлагам след това да запишете едни хубави криви за хемодинамиката, да ни ги покажете.
И ще ги сравним.
Именно. И ще се върнем към вас след малко именно за допълнителна дискусия. Не мисля, че има кой знае какво да се гледа повече. Тук за освобождаването на клипа, но след това дискусията за хемодинамиката смятам, че е доста важна. И моля да превключим при Чирков, да видим за техния случай, докъде са.
Assume extra support, it can stick on the wire and then... Has it happened to you before as well?
No.
So it happens a lot.
Oh,
You have to be careful. Yeah, it's stick and then you...
So, hi guys.
Hello. Where you are? What you have done?
Well, we've made some progress, so I will let Professor Shevket to guide you through.
Go back.
So when you left us, we were just about here.
Yeah. So we did parallel wiring here. You see, this was a Gaia 30 again. We could have also used the Conquest Pro, but it's very difficult to travel long distance with Conquest Pro without going out. So that was the reason we suggested for Gaia 30. And then we were out, as you have seen as well. Then I asked for a polymer jacketed wire, and it was Pilot 200. Go. It was my last attempt. It was my last shot, and I was about to switch retro. But you see, the Pilot 200 went into the true lumen, and I made this last shot because I poked around a lot with two Gaia third wires. That means I have created some kind of fenestration during the track of the CTO, and my hope was that I am going to enter in one of those fenestrations and hit the true lumen, and as it happened, as I awaited, but if I hadn't had the chance of doing that, we were about to prepare going retro. You see here I am in another diagonal, maybe side branch, and then we will checking it from two different orthogonal views. This is the RAO. We are in a side branch there with our Pilot 200. And now you see I am redirecting my Pilot 200 in every side branch. That means we are really in. So it's not always sufficient to check with one determinator. So you have to check with different factors like side branch entering, maybe sometimes tip ejection is not advised, but you see here we are nicely in the true lumen, so we entered side branches. And then we went on. We went with the Corsair Pro again over this Pilot 200. You see the buckle of the guiding catheter, how it is flipping of the coronary ostium, and Dimitar gave some push to this extra backup guiding catheter. So sometimes it's two-man job to finish the job, and he made some kind of, pushing of the guiding catheter, and I rotate the Corsair down the CTO. And now we put an extra support wire there. We ballooned with 2.20 millimeter balloon, and we put a wire, Sion blue wire, into the diagonal. And now we are planning to make an IVUS. And here comes another issue. We have a left LAD ostial lesion. Should we going to cross the stent from left main to LAD? We will decide after the IVUS, and we will decide the stent length, we will decide the stent size, diameter, what kind of diameter stent we are going to put there because this is a calcified lesion, and everything will be a little bit clear after the IVUS. So now we are facing a left main LAD ostial dilemma.
And we would like you to guide us what we should do.
You have done the job. I don't know what you suggest, but I'm a little bit, maybe if the osteo LAD is more than 3 square millimeters, probably it would be good not to be too aggressive today and to fix the CTO, and then maybe after a month to do FFR for this osteo LAD. Otherwise, you have to stent the left main.
We shall see now from the...
Because, as I said many times, there is no such a thing like an osteo LAD. This is a distal left main 010 in this case.
So Professor Vasiliev, now we're going to use the HD IVUS from Bracul.
So we are using the assist device here.
Yes, we're using the assist device.
The assist device, it's very useful when you want to save contrast, okay? That's a good thing because you give it with more pressure with a low contrast volume. And now I have the assist device, and this is going to be the first time I'm using this IVUS here. I have been used to do a lot of IVUS with Volcano and with the Boston IVUS, but I have the feeling this is one of the best here because I have searching this IVUS a lot, and now I have the privilege to use it.
Can we see the IVUS?
Yeah, it's coming now.
Yeah, for just a sec. We show them the IVUS, please. Господин, там снимайте.
So Vasiliev, I totally agree with you. I am not a fan of managing the LAD ostium. It should be another procedure, if it's needed. But yeah, but let's see. I have also here my guidance of Dimitar.
So maybe we should go cranial and see where we start.
We
start distally?
We are deciding together because it's his patient. So let's
go distally, please.
Yeah.
Yeah.
It's going nicely down. We just ballooned this area with 2.0 balloon.
So record.
20.
So we are going to record, and you.
So what was the balloon?
2.0.
The brand of the balloon.
It was re-raised, Thermus.
Okay.
It was re-raised.
Can I see the IVUS there, or should I look?
You can stay there, and I will take it manually back.
Okay.
So you will be blinded.
I'm seeing it from the monitor where I see you guys. So.
Okay, so this is HDI system from Assist.
So we have a side branch there. What is this?
This is the LAD. I'm starting to withdraw the catheter.
Manually?
Manually,
okay.
Yes.
Why don't you automatically?
I prefer it manually, to say.
Because
if we have some point of interest, we can always go back and forth.
So we have degree of disease here. It's 2 point something.
Usually my strategy is to do automatic pullback first run to hold.
It's underfilling. The artery is underfilled here.
To see, and then if I'm interested in this, IVUS has a huge advantage because you can leave the
Where are we now?
coverage of the transducer at distal place, and then you can move freely by the probe where you want without need for re-entering. By manual, this type of manual pullback, actually you remove the whole
This is side branch. What is this? Is it diagonal?
This is the diagonal branch that we protected with the wire.
With the wire protected?
Yeah.
Okay. So then we have 1, 2, 3 something. Huh?
So in the proximal LAD you have quite a good.
This is what I'm talking about. This is the LAD.
Amount of calcium.
And now I'm going slowly back and out.
You have a problem with the catheter. Yes, it
is.
So
it's gone.
Give me some comment about what I have the impression about this HD IVUS here. So with Boston IVUS, the microcatheter is flimsy, you know, but if you have sometimes you have some kind of difficulty in pushing it and then it will get kinked. But this one is a little bit more robust. And I don't know what French is this here, the French size?
Of what? The IVUS?
Yeah, the IVUS French size.
3.5.
So, but this
3.4.
Yeah, okay. This is the appearance has high quality. The images are good, so I like it. And I want to have this in Turkey as well. And this is a call for the
so Professor Şevket, distally the vessel looks like
for the suppliers. So we need this one.
Maybe we should measure it. Please stop it here.
Okay, I think from the distal part, we need a 2.5 stand. We have calcification here, and IVUS is here of paramount importance, because if you put a big stand, you may end up with some kind of rupture. And if you put a small stand, then in the short, medium term, you may end up with some kind of in-stent stenosis, which is very difficult to treat afterwards. So therefore, we should go with a proper size. And we have some kind of calcification in the CTO segment, maybe some kind of scoring balloon or cutting balloon.
Yeah, we can do that. We can do that.
If we have some scoring balloon, we can go further with that one to ballooning and preparing the lesion for stenting. And the thing here with the calcification is we have to be very careful that we do not create any kind of rupture. And it's about 270 degrees in some levels, you know. So I want to hear the comment of for you regarding the IVUS images, because what I've seen from here is that we were totally true to true. So I had no extra plaque space, maybe a little millimeters. I couldn't see that because we had a lot of calcium there, and it hindered us to see the total lumen and the intima.
Professor Vasiliev, I'm sorry. Do you see the IVUS?
Yes, we see.
I think that we have this is the false woman here, and the true woman is compressed. That's why I wanted you to see it. Can you play it? Over here, it looks like this point plate.
Yes, but this is
like
very short.
You see here, I think this is the woman over here, and this is all false woman. You see? You see?
Yes, but
I think this is the truth.
This is a very short. Very short segment.
Few
very
millimeters.
Short segment, and I would not be just to go to re-enter in this. If that was the longer than, let's say, 10 to 20 millimeters, probably it is. It's good to try to re-enter and to be true to true, but this is not a problem at all, I think. This is my opinion.
So should we do like Professor Cortese yesterday said, do proximal and do maybe depth distally, or should we stent all the lesion?
It's up to you, but what I'm interested in about the osteo-LAD, what is the area, the ostium of the LAD, just because that will determine the strategy for what you do after fixing the CTO. Because it could appear that you have to fix also the distal left main.
Much better.
And then,
or you can leave it for the next stage for functional assessment.
That matters.
So play the osteo-LAD so Professor Vasiliev can make it.
Yeah, we will like to see the osteo-LAD, and then we will make a measurement there. As you suggested, Vasily, if it's not below 3 millimeter,
exactly.
I totally agree with you not to touch it. It should be a matter of another procedure.
I suggest we do the stent, and then we come back with the IVUS. We check the stent position, and then we check precisely the osteo-LAD.
Again,
okay, it's fair enough.
Thank you. Thank you very much for the guidance. Let's use 2.5 non-compliant balloon for
these short segments with the subintimal tracking of the wire should not bother too much the operator if they are, let's say, more than 10 millimeters, and if they compromise some important side branch which is inside this segment occurring this some septos or big diagonal from this compressed through lumen.
The first one was
Probably it is wise to try to re-enter. But in this case, there are no important side branches at the region of the subintimal tracking, so there is no reason to be too much aggressive. And
so this is another thing, I'm sorry to interrupt, but this is another thing that we learned from our experience with Professor Shivket, is that we have to check the ACT very, very often, because we need to keep it in above 300, right?
Yes.
Yeah.
There is exposure of too much tissue factor, so the thrombosis it's on the way. What is your dosage of heparin at the beginning?
We started with 10,000 because the male, he's a male, I think he's 90 kilos, so we started to, he's already on ticagrelor and aspirin. That's why we feel confident.
So my approach is always, my default approach is always going with 10,000 heparin, because I'm doing always biradial, and I am not, concerned about any kind of bleeding. And the procedure is always going to be longer than 1 hour. So if you put 10,000, if you have a high ACT, there is nothing to worry, but it will go down slowly. So just checking the ACT. But
so if the patient is 65 kilograms, you give also 10,000.
Yeah, it doesn't matter for me. I go directly with 10,000.
Okay. So we're going to pre-dilate, and then we plan to use actually the new Terumo stent.
Okay, just let us know when you are ready for stenting, and we'll go to Tokuda just to see
thank you.
What they have done with their case.
Thank you very much.
So we make him from here.
Okay.
Може ли да превключим в Tokuda?
I'm not sure where we have entered.
Okay, so Bernardo, Valeri, hello.
Can we have some audio?
Yes, you have. We see you, we hear you.
So we have finished this quite complex PCI in this frequent flyer patient. So as we said, we tried to optimize the stent. We use a new OPN balloon at very high pressures, and in the end we got a good result in the IVUS. Then we had a couple of things. Okay, let's see the IVUS. This is after OPN. Huh?
The OPN, yeah.
Yeah, so we assessed the IVUS and the result was good. But look at here, it will come in a second. There is, it's going very slowly. Yes. Just distally to the stent, there is a hematoma. Probably the shoulder of the OPN balloon.
Can you switch on the bigger screen the IVUS?
Yeah.
Може ли да ми превключите IVUS на големия екран, да го виждаме, не да е толкова в ъгъла?
Yeah.
Да, мерси. Okay.
So there is a hematoma just distally to the stent, and then the stent. Okay, we can go to the stent. The stent was pretty well prepared here. So in the end, we decided to use DCB, but the trick, I believe that many physicians would have placed a stent there. That would be a big mistake, in my opinion, because first of all, try to manage it with a DCB. This is a patient that probably has some issues with the metal, some resistance or whatever, I don't know.
Dr. Cortese, what do you think about not just a balloon angioplasty, but scoring balloon angioplasty before DCB for this hematoma?
I think it could be a good alternative. Alternative, yeah. We use it quite a lot in the de novo lesions, but if you mean, okay, let's squeeze the hematoma, I think that's a good idea. But we didn't do it today because we had an open scoring balloon which was a little bit too large.
Okay.
So in the end, we delivered the drug there, and all along the LAD, up to the ostium of the LAD, we just pushed the struts that we had to, distort a little bit for treating the circ. So that's it. Can we show the angiographic results, the last two?
What we have as a minimal stent area is 5.6, which I think is acceptable.
It's good.
This is
more than 5, it's okay.
Yeah.
More than 5, it's okay.
5.5, 5.3, but 5 is a good, is a predictor of an eventful future.
So the hematoma
let's
was a little bit nasty at the angio, but here now it's the final result. I think it's very good.
It is really a good option because if you go further with stents, probably in the future you have issues with the place from Maria placing there.
Oh, yeah,
You should keep that in mind.
But we are optimistic that we will not have this option for the
Believe, and faith is very important.
Yeah.
Okay, so thank you so
Thanks,
much and congratulations for the great result, really.
Thank you. Thank you. See you soon. Bye-bye.
So let's switch to CT. Иво, отново си онлайн. Привет. Ама не те чувам. Може ли звука да оправим?
Do you hear me now?
Yes.
You hear me?
Да. Давай.
Okay, excellent. So we are showing the progress and the finalization of the procedure. We are going to show you in fact the removal of the delivery system, in fact the stem that is okay, stay like that. On the floor you are going to see how the
Може ли да видим флуоро
Yeah.
екрана? Защото не го виждаме тук. Да. Окей, мерси.
Okay, super. So you are going to see how is disconnected. Yeah, exactly at that moment, how is disconnected. The clip is already disconnected, and hopefully it stayed on place. it didn't move anywhere. No embolization. Next, and after that we are releasing the curve. And we are keeping inside the catheter for the delivery. And we are finally releasing the sheet. And we put, I'm showing here the Z shape, in which we are closing with a simple Z shape suture. We are closing the venous site without any further.
What is the sheet size, French size?
24. It's 24.
Okay.
And now I'm giving the word to Slavek to say several words regarding the case and some tips and tricks and so on.
Can we see the curve, because I see very
definitely. Just a second. We are going to show you now. Yeah, please increase.
Because you recorded it, but it is very small. Can you? Okay, great.
Yeah, in fact, this is after. You see 13, and this is before 34 by 5 with a huge V wave, huge, reaching 30. So this is before, and this is after. As I mentioned, it's a double less. So the hemodynamic is really impressive, and you see on the left side screen the echo with after the releasing of the mitral clip. We mentioned already that in some cases after releasing the mitral clip we can have some increase of the regurg in case there was some tension between the tissue of the valve and the clip, but in this case obviously there were no any special issues regarding the tension.
Okay, so now you can summarize the case, yes.
Yeah, Dr. Slavek.
I mean, that case was one of the best cases scheduled for the mitral clip. The mitral regurg, if it's central, is really very well done by clips. We can do a little bit worsened anatomies, but it could be something like second step. So the operator should knows how the clip is behave during the procedure. So after 10, 15, 20 cases, you will go for much worse anatomy, and you will find out that still the clip is working quite well. In our hospital, which is in northeast part of Czech Republic, We performed 350 patients till now, and we performed some analysis how looks the survival rate. And fortunately, what we found that even if the regurg is grade 3, there is no difference between the survival rate between the groups. Only grade 4 should be changed or covered by any other procedure like surgery, but we can do also the tendine implantation with releasing of the clip from the mitral valve.
Thank you. Thank you for coming and for helping us.
Thanks a lot.
Колеги, това е всичко
Поздравления, Иво.
селекция. Благодаря ви. Благодаря за вниманието.
Страхотна демонстрация. Нека да се върнем в болница Чирков.
So you want some contrast or? Okay. Bye, guys.
Guys, you have all the time till the end of this live transmission.
Oh, let's show you what we have done so far. We pre-dilated with 2.5, and unfortunately, we have some dissection of the osteo LAD, as you can appreciate from here. Can you see the angio?
Yes.
So we have dissection there. Maybe you should continue. Sorry.
Yeah, so we are just putting here, this was our last shot here. And the dissection seems to be limited just at the proximal LAD, and we are not sure whether it's going into the left main or not. We will do an IVUS afterwards. We put a stent in the distal part. So the distal part, we have a stent now. Our stent is 2.5, 38 Ultimaster stent. So
Nagomi?
No, it's the Ultimaster. So we will just want to go after the dissection there, and we want to limit our stent usage coverage here. We don't want to put a lot of stents in the distal part of the LAD. So we will see after the image, after the stent, how we're going to proceed. So now we are trying to go with the 2.5, 38 stents just after the dissection. So I go a little bit back.
Okay.
Maybe some contrast to see where we are really. Okay, this seems good. Okay, let's go.
Okay. And the proximal stent will be the new Terumus stent.
Go. How much pressure?
We have 14.
Okay, go 14.
14. Wait. The new stent, maybe Professor Vasiliev could comment if he has any experience with it.
Maybe Florosto. So you see.
Unfortunately, not.
So this is a new
but maybe from the panelists who have some experience with the Nagomi? Nobody. So
this is the new stent of Terumus. It's built on the Tansei platform. It's still biodegradable, sirolimus. The best thing about this stent for me is that it has lengths up to 50. So we have from 9 to 4.5 up to 50 millimeters in length. And its overexpansion capabilities are perfect from 4.
So can we call the area? So we will measure the length, maybe to the caudal, right caudal, and then measure or to apicaudal to measure the length of the.
So from 4.5 we can go up to 6.3. So it's perfect for left main and bifurcation.
Can you give me some contrast?
Yes, for sure. So we have been having a discussion here. Maybe we should pre-dilate here again. Do you want to? It's 2.5. We can.
Okay, let's make it.
We have a diagonal branch that has stenosis in its mid part that looks severe, and we were thinking about ballooning it before stenting and jading.
Okay, go down. So maybe we will take a shot and then.
Okay, then decide what to do. Maybe some nitro. We haven't used nitro.
Okay.
Blood pressure is perfect.
Okay.
So
you have to be always careful when you're retrieving your balloon. You can you can lose your wires. So this is always a two-man job. And I have an excellent co-pilot here.
Okay, so we have to help the patient a little bit. He's feeling very well, but he needs to pee. So we will give him something. So because that's why the blood pressure is so elevated.
Okay.
So but we can still
give some nitrate.
Maybe we should make a scene.
Okay.
To see what's going on with the LAD. So you see, the sheetless catheter is very useful because we have 3 wires and no friction inside, and we can use balloons and stents and whatever. Unfortunately, you want some contact?
Yeah, angio, please.
Angio, see?
Yeah.
Okay,
let's go.
So practically now, because of this dissection at the ostium of the LAD, maybe it would be good to stent to the left main. Just
yeah, that's what we were thinking.
So
do we need an IVUS or should we?
You had IVUS. I think that you should proceed directly with stenting of the left main and then to check the result with IVUS.
Okay, we'll follow your advice.
And
what about the diagonal? Maybe we should do left cranial to see the diagonal before we stent, or you don't?
Maybe yes, or AP cranial. AP cranial, 35 to 40 degrees gives excellent view on the proximal LAD diagonals.
I'm going there. We can see the dissection from here, so where it's expanding. So
okay.
Okay. Well, it's limited. So this diagonal, I don't know about. Maybe we should leave it like this.
Maybe it would be good if you have, because you have a small balloon with a 2O balloon with two or three atmospheres, just to massage this.
Okay, give me 2O balloon, please.
2O balloon.
Yes, with very low pressure, just not to dissect, because sometimes this is spasm. And surprisingly for me, but I found that not in all cases it responds to nitroglycerin. But very low pressure, 2-3 atmospheres.
We have 2.5, and we can take
maybe 2.0 would be, because 2.5 for this vessel. It's
2.0 balloon, please.
We have it on the.
No, it's 2.5. We use it for trapping. So we have fresh new, not Voika balloon.
But we do the 2 or something.
Sorry?
We used the 2 or something for the LAD. We have used 2 or no, wait.
Wait, we have a 2.0 actually.
We have 2.020 first.
Yes.
We should have. We had a balloon at the first, before we go with 2.5, we had a 2.0.
Yes, because you made the initial calculation with the 2.0.
Yep. So this is the balloon. I forgot about it, sorry.
How to say, cost effective.
Yeah.
Yeah.
So we have the same issues. I am accustomed with your behaviors here, and I am trying to save as much as wires as I can, but in a live case, we have to be a little bit more, the safety first.
Is it sticky?
Yeah, a little bit sticky, but I can manage to go. If you make suction, please.
Suction? Негативно. I'm holding it. So after all, we live on the perfect place in the world. We're all Balkan people, so.
Balkan people with the same behaviors.
Yeah. So now, just POBA, low pressure at the diagonal. Okay.
Okay, suction, please.
It's sucked. So maybe I should do it again.
Yeah, you should.
Yeah.
Or another option is that this is not a spasm, but serious stenosis.
Yeah, it is a severe stenosis. We've been seeing it from the first. Maybe we should take a fresh new one,
Maybe you should balloon here.
Balloon here?
Yeah.
Yeah, okay. Absolutely. 2-3 atmospheres at that. Yes, exactly at that point.
Okay, go down.
Exactly. Several low pressure inflations and.
Again, please.
Yes, you have a progress now. This from proximal to distal dilation. It's unwritten rule is that you should dilate from distal to proximal, but rules are to
Go
be
down. Yeah, go up.
Go up.
Yeah.
to be broken.
It's
Go down.
quite torturous.
Have we?
Not only, probably
Have we
there is
covered,
a significant.
have we covered
No, we haven't.
No.
Sorry, we haven't.
Okay, so then.
We have to.
Oh, I don't want
Maybe we should. Yep, this is it.
Okay.
Is
this the one?
Yep, but I think a little bit back because this study is.
Okay, now you should check again.
Yep.
Check again, please. I think.
Okay. So maybe prolonged inflation here.
Yeah, you got it. You got it there.
Okay. 10 atmospheres.
Yeah. Go down. So we should put at the ectosteum also. Go up, and then we should put a stent there. So that's it.
From the left main to the other.
Yeah.
So we're gonna use the 3.5, then the new stent, Nagomi stent. Actually, it's a very interesting name, Dangomi. In Japanese, it means harmony and how to find. It's a kind of philosophy, I think. How to find balance in different things in life and to live a harmonious life. So it's a very nice name. 3.5 the length.
Mitko, I see that you're a fan, as me, of Japanese culture.
Absolutely. Especially Japanese whiskey. 3.5. We have the 28, 33, 38.
That's very hard,
50.
by the way.
Let's see it from the AP right cranial, then decide the length of the stent. Here, I think. Okay. I think we should get rid of the.
Sorry. Okay, we'll get rid of the right. Okay.
So just only for
Okay, for pressure.
For pressure. And if we have.
So.
I will go a little bit in again.
Okay. So.
And now let's make an angio.
Angio. Okay. Ready. Nice dissection.
Okay, give us 3.5, 38, huh? What do you think?
38 will be much longer. I suggest we measure it with a balloon.
Okay, give us a balloon there.
We have 2.5, 25 balloon, non-compliant balloon. Give it to us, please. We have it on the table. We have it longer, 25. We have 2.5, 25. This is it. This is the minute.
Yeah, but as Dimitar pointed out, it's very nice here to work with the 8.5 inner lumen diameter of a guiding catheter. It's very comfortable here. So the sheet width is 6.5, the outer diameter, but the inner diameter is 8.5. That's excellent.
Did somebody from the panel have some experience with the sheetless guides? No? From the audience, some comments?
So it's very hydrophilic, Sometimes we have some difficulty going with regular. This is 25.
25, you see?
Give some contrast. No, contrast.
Sorry. So maybe we'll go cranial.
No, it's okay. 30 something. What do we have?
Yes,
25.
you
35. We will
yes.
use 35.
30 or something. This is
35. This is 25. We use 35. Okay.
Because in this projection, the proximal marker of the balloon is exactly at the edge of the plaque in the left main. So,
we will
maybe
go cranial.
5 millimeters more safety
Just
margin.
to cover the ostium. So you see.
Okay.
Yes, my intention always when I stand left main is always to go up to the ostium.
25. We need a longer one.
38 then.
38 then. 38. 3.5, 38. Nagomi stent. Yes.
Are you planning only to stent the ostium of the LAD, or are you going to reach the ostium of the left main?
We're going to stent all the way to the ostium of the left main. There is a plug there. There's a dissection in the proximal or ostial LAD. It's safer for me. I don't know about your experience.
Yeah, but we have this latest experience about not stent shortening, but actually stent prolonging. And there is now a debate going on whether we should cover the ostium or not, because then we have some kind of, in the long term, then we have some kind of struts hanging on the aorta and it's going to prolong. So either way, it's okay for me. So, but we don't have to be very afraid and concerned about the ostium. The stent will cover it anyway in the long term.
So you plan to place 3.5 Nagomi?
Yeah.
Yep, and we're going to post-dilate with, we will measure now, from maybe I will ask Dr. Stoyanov to measure the left main, distal left main.
This is the stent will be 3.5 to 35, yes? 38.
38, 3.5, 38. We have the circ, which is let's say 3.5. I don't know what do you think, Professor Vasiliev, but we have 3.5 LAD, 3.5 circ. Maybe we should post-dilate at least with.
Well, 70% of 7 millimeter summit diameter, it's maybe 5 balloon, but you have IVUS just.
Yeah, we have it.
You made IVUS just measure it from the IVUS. It is
but it's a practical tip if you, maybe we should post-dilate.
Yeah, we should dilate there. Something is happening there. Okay.
Okay, we pre-dilate with a bigger balloon because we haven't pre-dilated there. Give us a 3.0 non-compliant balloon for the proximal LAD. Yep. 3.0 is okay for you?
Yeah, yeah.
Okay.
So the thing with the shitless is it's very helpful when you have some kind of spasm in the radial artery, you know, because this is very hydrophilic. And with some kind of guiding catheter, you may not be able to reach the coronary artery. But with this one, I have seen some cases, and I have experienced some cases that with this hydrophilic, shitless, you are very easy to go through to the spasm and reach your aorta. So that's the beauty of it, and of course the inner diameter.
So we're taking the non-compliant balloon to balloon. Yep,
so you make additional predilatation of the ostium.
I think that the stent is 2.5 and it's not optimized, and the other stent would not go.
Exactly. Mm-hmm.
Yeah, give us this, and we can lose the next stent if we force it too aggressively. So we should post-dilate with 3.5 NC balloon.
Yeah.
And then we advance. I'm sure we will advance very.
Can you give some information about the elasticity of the stent? I mean, 2.5 stent up to what maximum diameter could be post-dilated?
We opened it just to see. We opened it at 14 atmospheres. So where is it? Because this is the first time for me too, to be honest. Can you give me the stent?
Okay, let's go.
Can you give me another stent so we can still?
Okay. So this is 3.5, yes?
3.5 NC balloon.
Okay. So 3.5.
Yes. Okay.
Maybe you could go a little bit higher in pressure.
It's very easy to see. Maybe we can do some stent boosting later.
Because you had a huge amount of calcium in IVUS, exactly at the proximal LAD. There was even one very short segment with the 360 circle of calcium. So here, yes, you see that there is a clear under-expansion of the balloon.
Again.
And probably it will be good to prepare very well in front the lesion with the balloon, just not to have problems afterwards.
Yeah, if it doesn't go, you should not push too much. Okay, if it doesn't go, then it doesn't go. You should prepare further rather than pushing. So if you push too much, then you will lose aureole system. And I would have preferred here maybe a cutting balloon or something if you have more than 270-degree calcification. But with the non-compliant balloon was opened very efficiently and without any dog bone effect. So that was the reason we were encouraged to do stenting after the non-compliant balloon.
So I have a question for the panel and from Professor Vasiliev especially. When we stand like here, hopefully we should, we will stand. You see the stand how smoothly it went?
After preparation.
I wanted to ask what's your opinion as very experienced operators when we stand crossover stenting like this, maybe a little bit. Do we need always to open the struts towards the circle?
No, again.
Yes. In my opinion, absolutely. I'm doing that in 100%. If you ask the colleagues from Korea, they will tell you that if there is nothing more than 50% stenosis idiosteum of the circumflex, just leave it alone. But I never do that. I always do kissing. We do now modified POCI technique for the optimization. This is pot combined with kissing. We already published.
What's the nominal pressure?
The nominal is 9. So it's,
wait.
So we wait. You see the blood pressure is stable, and then we.
I'm waiting in those cases until pressure goes below 100 and then deflate the stent.
We will do that as you are doing it. So that's
you have to have stone cold nerves, you know.
Yes, I know that many people are rushing just to inflate and deflate the stent. Nothing happens, and in general, if you implant stent, you should keep the pressure at least 20 seconds.
Okay, go.
If the patient goes unstable, if the patient pressure goes down, and yes, there is a resistance at the ostium of the LAD, but I don't. But I'm sure that they will
make some contrast to see whether we have any rupture or something. Okay.
But going back to the stent implantation, and I repeat that many times, just implant stents not for 1 to 2 seconds, at least 20 seconds, keep the balloon inflated.
Okay, 5-0 balloon. 5-0 balloon.
What was the measurement from the IVUS of the left main?
Unfortunately, I cannot tell you right now because I have to go over there, but
we go with
I will measure it again, so it's okay.
By following Murray wall,
let's bet on the panel. Let's measure from the Finet's wall, and
it should be 5.
Yeah, I agree. So you have at least a 3.5 LAD, and if we also have a 3.5, 6.
70% of 7 is 4.9 or 5.
Give us 5 also.
5-0. 5-0, 12, I suppose.
Yeah, and then we will do an IVUS.
Yep.
The beautiful thing about the left main is that you are not restricted with the balloon length, because if you don't have a very short balloon, you can use balloon with any desired diameter but any length, just because you can leave the balloon to protrude into.
What time do we have left? I'm sorry.
No.
Because we want to show you the IVUS later.
Do your job.
Okay, thank you very much.
I'm just commenting.
Sorry for interrupting. So you always do final kissing ballooning, as you mentioned?
Yes. Okay. In left main, I'm doing that in 100% of cases, because something happens, especially with this huge circumflex. In future, you will be at a big adventure to recross this stent afterwards.
Yes,
no matter that the pot is done, or how it looks perfect on angio. Now it looks perfect, probably because the entities you can see. Now there is a technique just how to determine is your pot adequate. You don't place a contrast inside the saline which inflate the balloon, and when the balloon is inflated at the pot, you are injecting the contrast. And if there is a contrast behind the balloon, that means that your pot is not adequate. With the contrast filled balloon, you can not do this technique, but in general, it is now it is recommended in 2023. Fuvar is a big fan of this technique, probably because he is not working anymore in the cath lab. And I personally always prefer to see how my balloon is opening. But anyway, guys, you have a perfect result. What I'm doing in those cases is just to pull the jail wire a little bit, just to see if the wire moves freely. That means that you need to do more pot. If the wire is jailed, and there is a resistance during the removal of this jailed wire.
That's a nice tip.
This gives you.
Should we go a little bit further?
Yes, the stent is really well opposed.
Let's go from the spider view, but just to be careful with the. So the comment here by Dr. Stoyanov is that we should advance the balloon distally because for him we haven't reached the carina. So
one
sorry.
point with the pot is that except the carina displacement and the carina shifting, is that during the pot you're stretching the carina region. During this stretch, this is
I think it's okay.
For me,
why I'm against placing the balloon marker at the carina tip.
Let's do IVUS. Let's do IVUS and we shall see. So I'm sorry again for interrupting. So we decided to do IVUS and then we decide whether we need. But distally the LAD doesn't look very, very well.
Maybe you should give nitro.
Yeah, maybe we should do that. What do you think?
And you have a little bit staining into diagonal.
Yeah, but the problem here is...
nitro, please.
The problem here is we have an extra support wire here.
Mm-hmm.
And this extra support wire is also causing some kind of spasm. And that's also hindering the distal flow here.
But give nitro and...
Yeah, I'm doing that.
We will do that. Let's put my balloon out first and then... No, wait.
Sorry.
So you give the nitro outside to it.
Yeah.
Okay, so now we can give nitro.
Dobry, is there a place to use clear stent on boost and placing and making the pot?
Can you fluoro? I use fluoro.
Now we make fluoro.
Except to feel huge satisfaction internal from the view, no.
This is good.
Practically,
I like it. This is good.
Okay. So do IVUS then?
Yeah.
Let's do IVUS.
It takes a lot of frames and it's not always perfect.
And the diagonal is working. Diagonal has symmetry flow.
Perfect. No.
You can be satisfied. Probably there is some dissection at the distal edge of the distal stent.
Yeah, probably. Now we're going to do IVUS and then you can guide us on whether we should do something else or we can leave it like this, because in our humble experience we don't always do final kissing. Има ли проблем?
No.
We don't always do final kissing on the left main if we don't have any problem with the circ. It's not a strict protocol. So we have patients that for more than 10 years have been done with simple crossover, and maybe you
we're on the wrong
the stupid mistake.
To be honest, we followed our patients, our left mains done. It's not so many cases, maybe around 200 for 8 years, and the kissing was a predictor of better survival. I underline this word.
This is very interesting results.
It's not only that, in my opinion.
You should publish it then.
I think that you should respect the next operator after you. For example, if there is a STEMI in the zone of the circumflex,
don't damage it.
You wouldn't want to have to open the cells at the STEMI situations.
I'm sorry, I didn't get that. I'm sorry, we were having some issues with this.
Can we see the IVUS image?
So this is the, maybe I will take it out and you can go?
Yeah, yeah.
You can comment on that?
So, okay.
So, can you record, please?
Nikolai will do together, come.
They cannot see the IVUS because of the camera.
Okay, okay. I am the IVUS. So you should see.
So I'm starting.
Yeah. Oh,
slowly. This is the stand.
Maybe we should go beyond the stand a little bit further. Go down again.
To go down again?
Yeah. We will see the edge.
Oh, you want to see the... Okay, so this is the distal IVD.
Yeah.
I'm going back.
Slowly.
So, because...
I am not seeing any dissection still here. This is calcification. Calcification still, stent will come. Any edge dissection?
Can you see the other story?
No edge dissection for me. So, and we have reached the intima very nicely, and we have a calcification here, and our stent is all in the intima. You see how it's going here. We don't have any opposition somehow, but it's okay for me. So this is the left main now.
This is the left main now.
Okay. Everything is covered. The intima is covered totally. And I would leave it like this one here. So for me, this is done procedure. If you have any other suggestion, then we can do further work.
Can we see again the IVUS at the distal part? Just only the vessel at the distal portion.
Yeah.
Just because I missed, apologize about that, but I missed the distal portion of the vessel and the stent edge.
You have to go, because I went and then I went back and then I advanced again. So maybe just a little bit further.
The last.
Yep. Oh, come on. Okay, so this is the distal IOID again. This is the distal IOID after the stent.
Is it possible to make an automatic pullback at 0.5 millimeter pullback speed?
Of course we can do it.
So why we haven't done it? Don't we have this?
Yeah, we have it.
You have some hematoma there, and there is a muscle bridge. This is a bridge there, which compresses until you practically implanted the stent inside the proximal part of the myocardial bridge.
This is the false lumen.
Okay, yeah.
You stented some very, very short part in the false. Yes, here.
It seems good for me. We should leave it.
Absolutely.
Okay, thank you very much for your guidance. I would like to thank Professor Shevket once again for his brilliant job here. We are really honored.
We will give you a final shot to enjoy. We are done.
Okay.
And thank you guys on the panel, for especially Professor Vasilev.
Let's see the angio finally.
You see?
Okay, yes.
Yeah, the flow is excellent, and we have TB3 distal flow. This is a complete success.
Absolutely.
So I'm happy.
Congratulations.
Thank you very much. Thank you. But the vessel will grow, you know.
Окей, това беше първата ни сесия.